Distinguished guests, colleagues, ladies and gentlemen, welcome to the International Pharmaceutical Federation Virtual World Congress, focusing on pharmacists as protagonists in mitigating antimicrobial resistance. My name is Sabiha Essack. I am chairperson of the Global Respiratory Infection Partnership, sponsored by an unrestricted educational grant from Reckitt in the United Kingdom. It is my pleasure to introduce my co-presenter, Manjari Garak, Vice President of the International Pharmaceutical Federation, Chairperson of the FIP AMR Commission, and Principal of KM Kundnani Pharmacy Polytechnic in India. Manjari is also the Vice President of the Indian Pharmaceutical Association and Chairperson of Community Pharmacy Division of IPA. FIP recognized Manjari with the Fellowship Award in 2016 for her services to community pharmacy and the pharmacy profession. In 2018, she was recipient of the Ishidate Award of the Federation of Asian Pharmaceutical Associations, the first Indian woman to receive both awards. Over to you, Manjari.
Thank you very much, Sabiha, and welcome everyone. It's my great pleasure to introduce Sabiha, my co-moderator, and she's the South African Research Chair in Antibiotic Resistance and One Health and Professor in Pharmaceutical Sciences at the University of KwaZulu-Natal in South Africa, and she's the chairperson of the Global Respiratory Infection Partnership, GRIP. And she has been driving these AMR events, which we are attending since last week. So thank you, Sabiha, for taking the lead and driving these AMR events and making it so interesting. We are here today for the Global Symposium, which is the culmination of our regional events. And we are here for the welcome and agenda, the first 10 minutes. Then we go to the regional best practice highlights from all the 6 regions. And then we have a very lively debate where we are going to debate about are pharmacists the protagonist in the fight against AMR. This debate rather, will be for 45 minutes. And then we will be discussing about the road ahead and also, if time permits, the Q&A. So thank you, Sabiha, and back to you.
Thank you very much. So Manjari introduced the Global Respiratory Infection Partnership, which was founded in 2012. And we published and global workshops that culminated in roadmaps to drive AMR action into the new decade. And this year, we took stock of the progress made on the roadmaps and identified best practice examples to accelerate AMR action through antimicrobial stewardship in the 6 regions. In addition to our partnership with FIP, GRIP has published several papers on the role of the pharmacists in antimicrobial stewardship, specifically in respiratory tract infections, as shown on this slide. And I'm sure that the chat will give you the GRIP website where you can find these and other resources. Manjari?
So the fight against antimicrobial resistance, AMR, has been a priority for FIP for last several years. And last year, that is in September 2020, FIP Bureau has set up the FIB Commission on AMR to continue its leadership on AMR and build on all the work done to date. The AMR Commission is composed of pharmacy experts from diverse fields, that is community setting, hospital pharmacy, academia, research, and they're all representing the 6 regions. The Commission's aim is to further develop that what pharmacy offers in the AMR fight and explore opportunities to increase its impact across all settings and scope of practice. It continues to drive the FIP Pharmacy AMR Roadmap, which guides actions globally, sustaining momentum and tracking and evaluating the progress of this global health priority for the pharmacy. You can also see all the 21 development goals here on this slide. And the FIB AMR Commission focuses on the implementation of the DG 17, which is specifically on antimicrobial stewardship, and which looks at how the pharmacist, pharmaceutical scientists, and pharmaceutical educators contribute to reduction in AMR. Back to Sabiha.
So our workshop objectives are to drive behavior change in AMR through learning examples from good and bad practice examples, and to highlight the leadership role of the pharmacist in antimicrobial stewardship. Manjuri, I hand over to you to go through the regional best practice highlights.
In last 1 week, we had 6 regional events, and the case study, the best case study was chosen by the audience. And so we have more than 1,000 participants attended these regional meetings, and the regional meetings were in African region, Europe, America, Southeast Asia, Western Pacific region, and Eastern Mediterranean region. And it was a great sharing of best practice initiatives
Khan from South Africa. Yasmin is a young pharmacist with a passion for research and academia. After completing her master's degree and spending a few years lecturing at Nelson Mandela University, she is now practicing as a ward pharmacist in a hospital in Gauteng. Over to you, Yasmin.
Good afternoon, everyone, and thank you for this opportunity to be here today. My name is Yasmin Khan, and today I'll be presenting a study which focused on the development of an undergraduate antimicrobial stewardship curriculum for the purposes of training undergraduate pharmacy students in South Africa. The development of this curriculum is important since we know the role of the pharmacist is rapidly evolving in antimicrobial stewardship, and pharmacists are recognized as key role players in antimicrobial stewardship teams. The development of this curriculum involved a mixed methods methodology, and it employed 3 primary study phases. The first study phase was a content analysis. This involved a review of national and international literature pertaining to antimicrobial stewardship and undergraduate antimicrobial stewardship training. The second phase was the academic review. The academic review involved quantitative questionnaires being completed by 1 representative from each school of pharmacy in South Africa. And the purpose of this questionnaire was to investigate the degree to which antimicrobial stewardship was being presented in each school of pharmacy in South Africa, and also to highlight what these academic pharmacists recommend be included in the curriculum that we developed through the study. The final phase of the study was the expert consultation phase. In this phase of the study, which was our qualitative aspect, we conducted telephonic semi-structured interviews with a multidisciplinary panel of stewardship experts in South Africa. The purpose of this study phase was to highlight the perceptions by these professionals regarding the role of the pharmacist in antimicrobial stewardship, and also what knowledge and skills these professionals feel pharmacists need to possess in order to effectively contribute to stewardship in practice. Collation of the results from these study phases allowed for the development of the final proposed curriculum. The curriculum provides recommendations in terms of both the structure as well as the content, which should be incorporated in the curriculum, and it was made available through publications in the American Journal for Pharmaceutical Education, as well as presentation at national conferences. Our hope is that this undergraduate antimicrobial stewardship curriculum could serve as a useful tool to facilitate the training of undergraduate pharmacy students in South Africa and ensure that all South African pharmacists entering into practice possess the required knowledge and skills to effectively contribute to stewardship. Furthermore, the methodology which was employed in this curriculum could serve as a useful tool to other countries and regions and facilitate the development of similar curricula to guide the training of pharmacists in antimicrobial stewardship and ensure that all pharmacists globally possess the required knowledge and skills to be effective antibiotic stewards. Thank you very much for your time. I appreciate the opportunity.
Thank you, Yasmin. Now we go to Americas, and can we have the previous slide? Now we go to the Americas. Yes, thank you so much. And the winner panelist is Sonia Umia, and she is the Director of Medicines Information Center, Department of Pharmaceutical Sciences, Cordoba National University, CNU, in Argentina. Sonia is PhD in chemistry, and she did a project in area of AMR, which was a collaborative project of CNU with Pharmaceutical Forum of Americas. Welcome, Sonia. It's all yours.
Hello, good day, colleagues, and thank you, the organizers, for the invitation. The aim of this project was to develop good dispensing practices, a program for antibiotics most in demand. The setting of this experience were community pharmacies in Cordoba, and the purpose was to diminish antibiotic resistance on one hand, and to empower patients by improving their knowledge about antibiotics on the other, why prescriptions is required, and how to use them properly. The project was carried out by the Pharmacists Association of Cordoba. It was planned and conducted by the Committee of Community Pharmacies. The first stage was the design of standard operating procedures and the training program. Then the involvement of pharmacists took place at the end of the educative activity, taught by teachers from National University of Cordoba and the Pharmacists Associations. And after that, about 200 colleagues recruited more than 2,000 patients and collected the data. The main result was that good dispensing practices, a program was developed and the procedures were validated, and the training course enhanced the educative role of pharmacists for delivering drug information to the community or referring to other health professionals when it was required. Online tools were also adapted to register and assess the professional activities. Well, the strengths are based on motivation and self-initiatives by colleagues. They decided to stop listening and talking about AMR and start doing something. They moved from good intentions to action, using good dispensing practices for antibiotics, most in demand locally. Strategic alliance with universities, health team professionals, and organizations at national or international level are opportunities to keep going on AMR stewardship. Thank you very much.
Thank you very much, Sonia, for keeping to time. Just for everybody's knowledge that all of the regional meetings have been recorded and the full case studies are available on the FIP YouTube channel. Our winner from the Eastern Mediterranean region is Khaled El-Jali, an associate professor in the Faculty of Pharmacy at King Abdulaziz University in Jeddah, Saudi Arabia. He's an infectious disease pharmacy consultant, chairman of the Infectious Disease Pharmacy Specialty Network of the Saudi Society of Clinical Pharmacy, as well as an honorary research fellow in the College of Pharmacy at the University of Arizona, Tucson in the USA. Over to you, Khaled.
Thanks much, Sabiha. Hello, everyone. Good morning or good afternoon. So the title of this case is Prescription-Only Antimicrobial Dispensing Policy in the Community Pharmacies. As you know, several studies in several places around the world, including Saudi Arabia, they showed that antibiotics are dispensed without prescription in the majority of cases. And we had a law in Saudi against that, but it was not enforced, and there was no clear punishment. However, 3 years ago, the law was enforced in a new policy by the Saudi Ministry of Health with clear punishment. I was honored to be a member of the National Antibiotic Committee at that time. Now, pharmacists who violate the law due to outbreaks of viral infections. Now, for the overall antibiotic utilization, whether sales in the figure above or DDD in the figure below, they were declined by about 10%. And if you look per 1,000 inhabitants per day, it was 17%. So the policy worked, but the impact was not as large as we expected. The antibiotic claims increased, which suggests a decline in the antimicrobial dispensing without prescription. And if you look at the figures, there was a sudden drop in consumption immediately after policy enforcement, but it increased subsequently. So it seemed that people found a way to get the antibiotic from physician this time with a prescription. So in conclusion, merely enforcing strict policies or regulations may not be sufficient alone to address antibiotic misuse. There is a need to implement educational and training programs for patients, physicians, pharmacists to raise awareness of the appropriate use of antimicrobials and maximize the effectiveness of these policies. I presented this study in ID Week last month's conference by IDSA, and I wish the study was published, but not yet, as it is currently under peer review by one of the journals. A message to the countries in the region and other region as well, that this can be done. It is effective. So keep pushing for this policy in your country. I believe it would have a significant impact in your country, but even when it is implemented, it is not enough alone. Keep working on antimicrobial awareness and other strategies to tackle antimicrobial resistance and optimize antibiotic use. Thank you very much.
Thank you, Khalid. Thank you very much. Now we go to the winner from the European region, and we have with us Katia Caneris, and she's professor in microbiology laboratory of Environmental Health at University of Lisbon in Portugal. She's also home care business and scientific director of Nippon Gases Healthcare. She's presenting on behalf of Philip Howard, who was the winner, who could not join us today because of some other commitment. And Philip is the president of British Society of Antimicrobial Chemotherapy and AMR Regional Antimicrobial Stewardship Lead for NHS England. Thank you very much, Katia, and over to you.
Thank you very much. Hello, everyone. I would like to share with you an intervention to get community pharmacy more engaged in antimicrobial stewardship. There has been guidance from NIS, that is the UK guidelines developer, that community pharmacy should be engaged in antimicrobial stewardship, supported by ongoing education and training. This tool has been developed to get community pharmacy to engage in AMS with every antibiotic prescription they dispense without increasing the time taken. An antibiotic prescription checklist was developed with practicing community pharmacists and a range of patients. It was then trialed in 12 community pharmacies after training of 43 staff to increase their capability, opportunity and motivation to check antibiotic appropriateness and provide self-care and adherence advice when dispensing antibiotics. It has now been included in the English Community Pharmacy Quality Scheme for this year. And in 1 month, more than 900 checklists were completed. And we are looking forward to the results of 1 year implementation. On the chat box, I will share with you this antibiotic prescription checklist in order to see that it has a high impact, but it's easy to implement. Thank you, everyone.
Thank you very much. Our next case study is from Southeast Asia, where Dr. Karthik Rakam was the winner. Karthik is a PharmD graduate from the first batch of PharmD students in India. He co-founded Avenida in 2021 with the vision to help create a better world by transforming the way healthcare is delivered and education is offered. His professional objective is to use his knowledge and skills to change the way pharmacy is practiced in India. Over to you, Dr. Rakam.
Namaskaram all. I'm Karthik Rakam. Though I am associated with many startups in various roles, I prefer introducing myself as a proud clinical pharmacist from India, which is the pharmacy of the world where medicines are made, and a country which is making huge strides towards pharmaceutical care to make medicine work effectively. In my initiative, I chose to involve pharmacists as soldiers, empowering them with knowledge, skills, attitude, and using technology as a facilitator to tackle AMR. The logic behind this approach is simple. All of us know our position as a pharmacist offers us a unique opportunity to be a bridge, get all the stakeholders like doctors, nurses, other healthcare providers, policymakers, and more importantly, the patient into this endeavor of tackling AMR. On the other hand, I realize lack of knowledge, confidence, belief, and drive is not really making pharmacists exploit our strengths and take the lead in AMR. Hence, I took an initiative which focuses on capitalizing the strengths, using the limitations and weaknesses as an opportunity to improve and take a step towards handling AMR. So how did I start and what did I do? Before I convince other pharmacists to take the lead and plunge, I wanted to test the waters myself, so which I did during my PharmD and got a good understanding from my own personal experience, which is relevant to the country and the situation here. So then I started to disseminate this knowledge through workshops by making pharmacists and students understand the problem in first place, the magnitude of the problem, the root causes, and possible solutions. This workshop touched upon all aspects of use of antibiotics, right from prescribing, dispensing, administration, monitoring, and follow-up. Emphasis was not just on learning, but learning from genuine resources and putting this knowledge into practice. So I jokingly say that our half-life is short, workshops inspire us for a week, then again we go back to same old story. So I thought of putting more consistent efforts by doing modules and involving doctors and other healthcare professionals in these modules to share their perspectives so that all the students get a broader idea and not just a pharmacist perspective. And followed by modules, we started engaging them in simple activities. Currently, we are doing a mentorship program from students, almost all colleges of PharmD across India, collaborating with the Indian Pharmaceutical Association, which is a national body. So by doing all this, we could create awareness about critical role of pharmacist in AMS among the pharmacists at first. And once we feel the pharmacists are convinced that they can lead, they have all the strengths and support, we felt it does not take much time for others to understand. And this has also resulted in optimizing the use of antimicrobials. We got great testimonials from a lot of hospitals and doctors. And going forward, we want to scale it up and create more impact. And I would like to thank FIP for this opportunity and looking forward to work with all of you in future.
Thank you very much, Dr. Karthik Rakam. Now we go to the Western Pacific region, and the winner from Western Pacific region is Leonila Ocampo. Leonila is a pharmacist who has wide experience in different pharmacy settings. She's currently a member of the Executive Board of the Western Pacific Pharmaceutical Forum. She's a member of the Executive Committee of FIP's Community Pharmacy Section, and President of the Western Pacific Institute for Medication Management. Welcome, Leonela, and thank you for joining. Over to you.
Thank you. Thank you very much, Manjeri. I am very happy to have had the opportunity to share what we are doing here in the Philippines relative to the program on antimicrobial stewardship. So this program started with the serious concern we had on the use of antimicrobials. So much misuse, abuse, irrational and irresponsible use was observed. And to put things move forward, we started discussions, we had the planning, and a team was there organized to conduct a study on the extent of antimicrobial resistance problem that we have in the country. So the study came up with, or was able to generate data that was organized, analyzed, so that we could utilize it as a tool to lobby for some changes in policy, most especially a policy that would restrict the use of antimicrobial in every setting where it could be used. So the data was utilized again as a tool to lobby for a directive from the Office of the President and into some local government units. So fortunately, we were able to succeed in convincing the president to issue an administrative order, Executive Order 42, creating interagency committee for the formulation and implementation of a national plan to combat antimicrobial resistance in the Philippines. This was done actually by the late President Benigno Aquino. And in response to this order of the president, the Department of Health created a team of health professionals, doctors, dentists, pharmacists, nurses, and the team was commissioned by the Department of Health to develop national guidelines in prescribing, dispensing, and administering or use of antimicrobial. So this particular team was able to successfully come up with national antibiotic guidelines that we are now using in the country that guides on how prescribing, dispensing, and use of antimicrobial happens. And in addition to this national antimicrobial guidelines, Antimicrobial Stewardship Program in Primary Healthcare Manual of Procedure is also published and was prepared by a team which was headed by a pharmacist. And we're very happy that the Department of Health, through all these initiatives, the details of this is found in the detailed report that I have submitted. We're happy that our group from the hospital pharmacies, the Philippine Association or Society of Hospital Pharmacists is now into an agreement with the Department of Health to run the training and even support the setup of EMS, Antimicrobial Stewardship Program in hospitals, while our Continuing Professional Education Committee of the Philippine Pharmacist Association is running a continuing education program to community pharmacists, and in fact also has a program to antimicrobial users to the community, so that we would be able to run parallel training to us pharmacists, and at the same time also conduct awareness campaign to the community on the proper and appropriate use of antimicrobials. So while we say that we know what we are expected to do as health professionals, it is always important that guidelines will be there set to guide everyone on what to do in the proper use of antimicrobials. So thank you very much. This is how we are in the Philippines.
So thank you very much to all of the winners of the 6 regional sessions for sharing the case studies with us. We now would like to ask you as the participants to vote on which one you think would be the most impactful in your region. So Carola, can I hand over to you for the poll, please? And we have about 45 seconds for each of you to vote. Please remember, the first case study was from Africa on the AMS curriculum. The second, Manjari, was from the Americas.
Americas, yes, Americas. Then the third one from Eastern Mediterranean, the fourth one from Europe, fifth one from Southeast Asian region, and the sixth one from Western Pacific region.
Great. So please vote as to which case study would be the most impactful and which is most likely to be easily implementable in your region. So we just have the one question regarding the case studies, and a reminder that all 3 case studies presented in each region is available as a recording of the regional sessions on the FIP YouTube channel. So Carola, can we have the winner? And maybe a drum roll. So it's case study 5, which is from India, I think, correct?
Yes, Southeast Asian region. So the winner was from India, Dr. Kartik Rakam.
Excellent. So we've had, it's actually been absolutely close, as you can see, between each of the case studies. And congratulations, Dr. Rakam, on being the case study that won at the global level. Congratulations to you.
Thank you.
Would you like to say 2 quick things? You're welcome to open up your
There is
video.
a lot of interest from students and pharmacists in India to play a key role in AMR. We would love to collaborate with you and work and see if we can create more impact. And thanks to all the pharmacists from India who selected, and all other case studies, there is a lot to learn.
So thank you very much, Dr. Rakam, and congratulations. And as I said, there are excellent case studies from every single region, and we encourage you to look into the YouTube videos of the regional sessions and have more detail on the ones that were presented here today. It was pretty close, as you could see from the voting, and we wish all of our regional winners all the best in upscaling these interventions, not just in their countries, but regionally and globally. So congratulations to you all. So this year's FIP GRIP session takes an innovative format. 2 teams are going to debate on whether pharmacists are protagonists or antagonists in the fight against AMR. Sorry, one moment. There we go. So Professor Debbie Goff and Dr. Victoria Ratta are led by Professor Parisa Alsani, who are our protagonists. Professor Nirmin Sabri and Manjari Garat, my co-moderator, led by Andy Gray, are our antagonists. So let me begin with a brief introduction of the teams. In the protagonist team, Parisa Alsani is the professor in medicines use optimization at the University of Sydney School of Pharmacy. She is currently Deputy Head of School and Director of Academic Career Development. She is the Fellow of FIP, currently an FIP Vice President, and immediate past President of the Health and Medicines Information Section. Professor Debbie Goff is Professor of Pharmacy Practice in the College of Pharmacy in Columbus, Ohio, in the US, and an infectious diseases specialist pharmacist, global antibiotic stewardship expert, and founding member of the Antibiotic Stewardship Program at the Ohio State University Wexner Medical Center. Victoria Ratta was appointed as the first Executive Director of the Commonwealth Pharmacists Association in 2016. She pioneered the highly commended Commonwealth Partnerships in Antimicrobial Stewardship Program. Dr. Ratta is a civil society representative on the Commonwealth Advisory Committee on Health. So that's team 1 and the protagonists. The antagonists are led by Andy Gray, who is a pharmacist and senior lecturer in pharmacology in the discipline of pharmaceutical society at the pharmaceutical sciences at the University of KwaZulu-Natal in Durban, South Africa. He's also the honorary senior scientist and consultant pharmacist for the Center for the AIDS Program of Research in South Africa, or CAPRISA, and non-executive director of GEMBI Health Systems, a not-for-profit company focused on developing computer or IT-based healthcare solutions for the developing world. I've already introduced Manjari to you. Suffice it to say that she's chair of the AMR Commission at FIP. And then finally, we have Professor Nirmeen Sabri, who is Professor of Clinical Pharmacy and Clinical Pharmacy Practice at Cairo University. Dr. Sabri is the chair of the National Medication Management Standards Development Committee in the General Authority for Healthcare Accreditation and Regulation. She's also a member of the Antimicrobial Stewardship Committee of the Egyptian Drug Authority. So I'm going to stop sharing my screen and then ask each of the, before I stop sharing my screen, just some ground rules. Each member of each team will get 5 minutes to present their case. The leads of each team will then provide a summation and a rebuttal, and you, as the participants, will decide on which team made the most convincing argument. And I ask you to put aside your inherent biases as pharmacists and really think about which of the teams is going to make the best case as a protagonist or antagonist. So I'm going to stop sharing the screen and ask Debbie, Professor Goff, from the first team to present her case. Over to you, Debbie.
Thank you. And good morning. It is quite early here in the United States, but I am so excited to take the protagonist viewpoint to show how pharmacists are proponents of the fight against antimicrobial resistance. And I'm going to share my personal experience working with hospital pharmacists in South Africa for the past 10 years. Their first antibiotic interventions were in the intensive care unit. We wanted to see if pharmacists could shorten the time from when an ICU doctor actually wrote the antibiotic order to when the nurse infused the antibiotic. We called this the hang time study. We know in ICU and patients with sepsis, every hour would delay antibiotics, mortality is increased by 6%. Antibiotics are to be administered within the first 2 hours of the diagnosis of sepsis. So pharmacists at that time, 10 years ago, were primarily in dispensing roles and delivered ward stock. So in that role, they worked with nurses to have them document the time doctors wrote the antibiotic orders and then when the nurse actually infused it. And they looked at documenting what the turnaround time was, and it was around 6 hours. So that puts patients' mortality rate upwards of 40%. So the pharmacists, through their interventions, were able to improve that delivery process and cut the administration time down to the 2-hour window from a baseline of 41% to 78% compliance in 33 hospitals. That is a pharmacist team making a difference. That success led to the next pharmacist-led antibiotic intervention across 47 hospitals. Again, these are non-infectious disease trained pharmacists who then had 1 hour of dedicated time to do antibiotic interventions. They would call the doctors for the following interventions. If they ordered antibiotics without cultures, they'd call and remind them to order cultures. At day 7 or 14 of antibiotic therapy, they simply would call and ask, are these antibiotics still necessary? These pharmacists made over 8,000 interventions and decreased antibiotic use by 18%. This was such an impact. This study was published in Lancet Infectious Diseases as the first successful pharmacist-led antibiotic stewardship intervention that decreased antibiotic use in a low middle income country and has been used as a role model study for many others. This was followed by a prospective audit and feedback intervention for compliance of surgical prophylaxis in 34 hospitals. We know how hard it is to intervene with surgeons. Not only did these pharmacist interventions improve compliance to surgical prophylaxis from 66% to 84%, their interventions decreased surgical site infections by 20%. That's a way to engage surgeons in antibiotic stewardship. This was followed by a recent pharmacist-led prospective antibiotic stewardship study to improve guidance, compliance to community.
30 seconds, Debbie.
To improve community-acquired pneumonia guidelines, and they were also successful. So I think these numerous examples from South Africa clearly prove the valuable role of pharmacists in assuring not only are antibiotics used responsibly, but that pharmacists make these interventions and they result in a decrease in antibiotic use, which is the main driver of antibiotic resistance. So I say, case closed. We've proven their impact. Vote for the protagonist. Thank you for your time.
Thank you very much, Debbie. Our first speaker for the antagonist is Manjari. Manjari, you have 5 minutes starting now.
Thank you. Thank you, Sabiha. And I'm going to focus on the community pharmacy practice. I'm a very strong advocate of the pharmacist role. And I believe pharmacists are the gatekeepers of health. But there are many ifs and buts, because when you have a reality check done in some parts of the world, you know that the pharmacists are not up to their role, and they are more like traders than the healthcare professionals. This happens not in the entire world. Again, I just want to tell you, this is in some parts of the world, but the population they serve is significant. And so I'll just discuss about 2 or 3 scenarios as the time permits. So the first scenario, a patient walks into pharmacy, patient has a stomach ache or patient has a sore throat, and he asks the person in the pharmacy, give me a strong medicine. I just want to be okay fast. Pharmacist hands over ofloxacin for the stomach ache, or maybe azithromycin or erythromycin or something of that sort for the sore throat. No information given, no questions asked, antibiotic is dispensed over the counter. And the patient walks out, he is not aware that what he's buying is an antibiotic, which is much, much different type of medicine than the other types of medicine. Scenario 2, now a patient has a prescription. That's not a case of self-medication. Patient walks in the pharmacy, gives the prescription, and the person behind the counter, a pharmacist or a pharmacy team member, dispenses the antibiotic. Correctly dispensed, no problem. But no information given, no questions asked. Patient walks out of the pharmacy. Patient starts feeling better in a day or 2. The course was given for 5 days or 7 days or maybe 10 days. Patient is not aware of importance of completing the antibiotic course. Patient leaves the course in a day 2 or 3. And there is now scope for the resistance. So the adherence is the issue which is not addressed by the pharmacist. Patient is not educated on this. Third point, there are in many parts of the world, the pharmacist, the qualified registered pharmacist is not present in the pharmacy. And the person behind the counter may not be always a pharmacist. It could be just a pharmacy team member. Now, that's why I say, if the pharmacists are not doing their job, they are not acting as a pharmacist, if we remove that P from the pharmacist, it could be just pharmacist, then they are contributing to the antimicrobial resistance. They're dispensing the antibiotics over the counter. They're not doing the counseling, which is much needed for the adherence, for the patient's understanding. Then this is contributed and must have already contributed to the antimicrobial resistance. There is a lot of need. I'm not saying that the pharmacists are to be blamed alone. No, we have learned from the case studies also. What is needed, it changes in the regulation, from the education to the regulation, the law enforcement, also consumer sensitization, increasing the capabilities of the pharmacists by training. So we need to create a right ecosystem for the pharmacists, and pharmacists need to understand their own value. What are they for? They're for the patients. They're handling the medicines, the antibiotics. And then if they do their role, they could be protagonists. But this is not happening in many parts of the world. And that's why I say that the pharmacists are antagonists and they are contributing to the antimicrobial resistance. And the situation needs change. This is an alarming situation and we need to act very fast And we need to equip the pharmacists with the right knowledge, also improve the law enforcement. And there are so many measures which need to be taken to improve this situation. Thank you very much, Sabiha.
Thank you very much, Manjuri, for that submission. Parisa, over to you for the protagonist's 5-minute.
Thank you very much, Sabiha. Good morning, good afternoon, and good evening to my fellow pharmacists across the 4 corners of the globe. You're all here because you're passionate about appropriate antibiotic use. And I have little time to convince you when you're already convinced that pharmacists are protagonists for appropriate antimicrobial use. Pharmacists are the missing link between mediocre healthcare and optimal healthcare. They are the key that unlocks quality and rational use of medicines, including antibiotics, be it in the community or hospital. Pharmacists are critical to optimal use of antibiotics, and they are the instrument that can fight against inappropriate antibiotic use. You have heard of numerous examples, and you've noticed some of them in today's presentations. But however, in many parts of the world, pharmacists remain a hidden secret whose full potential is not effectively utilized. And that's why the other team can bring up some poor examples of pharmacist practice. You have seen numerous cases of effective roles, and the evidence is strong on what pharmacists can do to optimize antimicrobial use. But let's focus on the collective evidence rather than individual cases. Firstly, I'll cover the pharmacist's expertise and therefore why they are effective protagonists of AMR. Then the roles that pharmacists play, which have been shown to have a positive impact on appropriate antibiotic use. And finally, what can we do tomorrow as pharmacists at our very own workplaces to demonstrate our impact in AMR? Pharmacists are the experts in all things about medicines. As you know, they're the only healthcare professional globally who spends 3 to 5 years at university learning about medicines, more than any other healthcare professional, including doctors and specialists, who, may I add, prescribe medicines and are probably one of the maybe worst healthcare professionals in promoting inappropriate antibiotic use. As pharmacists, we know all about the available antibiotic classes. We know what to use, when to use, what's the first line, what's second line, what's third line. We know how to optimize formulations. We know how the drug is released in the body, how it's absorbed, how we can manipulate dosage forms and structure of antibiotics to ensure optimal absorption and distribution. We know about metabolism and excretion. We know about antimicrobial resistance. We know what causes it. We know about side effects. We know how patients use it. We know how to advise patients. As antimicrobial stewards, there is extensive evidence to show what pharmacists are currently doing and which has had concrete evidence on the positive impact that pharmacists, in fact, have had. In Australia, the Australian Commission on Safety and Quality in Healthcare clearly defines the evidence-based role of the pharmacist and pharmacy services in antimicrobial stewardship. They recognize the important roles of pharmacists in hospital and community settings through supply and access, patient counseling and advice, monitoring use and feedback on use to both healthcare practitioners as well as to patients, health promotion and health advocacy, and patient education. We have strong roles that are evidence-based and the outcomes you've heard about, and outcomes that you know as case examples within your practice. Pharmacists are recognized as leaders, as medicine experts, as guideline developers, as patient educators, as healthcare provider educators, and as drug use reviewers. So imagine yourself in the role of a protagonist. Here is what you can do, and here is what your other colleagues have done to make a difference globally and in large numbers. And the evidence is there, rich and strong. You can advise prescribers on the right antibiotic for the right bacterial infection for the right patient. You can formulate the right dosage form for the infection site and the patient. You can advise on the right dose, the right strength, the right frequency, and the right interval for the antibiotic therapy. And you can advise patients on how to take their antibiotic correctly and for the correct duration. You can write guidelines in hospital formulary which determine and steer the correct prescribing. You can lead antibiotic surveillance in hospital and community. You can monitor antibiotic use and effects in patients, and you can develop public health campaigns to educate the public about when antibiotics should and should not be used. In conclusion, we are the gatekeepers to health. That is correct. We see a lot of inappropriate antibiotic prescribing, but the evidence is there to say that we do make a difference, that we support the positive impact of the role of the pharmacists in AMR. And there are a range of opportunities that each and every one of us are involved in and can be involved with tomorrow when we're in practice. Pharmacists are the protagonists
15 seconds, Felisa.
of the fight against AMR. Thank you, Sabiha. And thank you, everyone.
Thank you. Thank you very much, Parisa. Our next speaker from the antagonist group is Professor Nirmin Sabri. Over to you, Nirmin. Are you muted, Nirmin? You muted?
Hello?
Yes, we can hear you. Please go ahead.
Thank you very much. Hello, everyone, and thank you very much for the invitation and actually for the initiative. And I'm really sad to be in the antagonist side because what I do see with respect to the role of the community pharmacist. What I'm going to speak about today is related to an actual things we've been evaluating for a while, where we evaluated like 36 pharmacy in Great Cairo with more than almost 900 patients requesting antibiotics with more than 1,100 items being sold. Surprisingly, we found that more than 25% of the items being given to the patients, they were given without a prescription, and only 55% of these items being given by pharmacists, the rest being given by non-pharmacy staff in the pharmacy who don't have any backgrounds related to the medications, unfortunately. And it was found that when we evaluated the prescriptions or the items being sold to the patients, surprisingly, we found that these items being sold for sore throat, cold and flu, rhinitis, abdominal cramps, asthma, dizziness, irritation, even abortion. The antibiotics were given for them without a prescription, either based on pharmacy recommendations or based on self-medication by the patient themselves. When we evaluated these items, we found that more than 50% of these items were not reviewed by the pharmacist. And surprisingly, when the pharmacists tend to recommend antimicrobial agents, they normally recommend broad spectrum antibiotics and newer agents, albeit none of them were appropriate for the indications or being reviewed. When we started to discuss it with the pharmacists about the practice related to the antibiotic prescribing and do they think that they can impact the antimicrobial resistance and have they heard about the antimicrobial stewardship, all of them agreed on the fact that what is the problem? Antibiotics can be easily bought directly from the pharmacy without a prescription. And some of them actually highlighted a major thing, that the pharmacy owners, they do pressure them to achieve higher revenue. So they are just pushing them to do the sales of the antibiotics and antimicrobial agents. Also, the pharmacists showed concerns that the patients and the carers' expectations pushing them to dispense or to sell antimicrobial agents because the families and the patients, they do believe that antibiotics can prevent any disease. And we've been very surprised to know that the pharmacists, they do not know that there is a law preventing the selling of the antimicrobial agents without a prescription. And they said if there is a law like that, so the regulatory bodies, they are not enforcing it. Regarding the terminology of the antimicrobial stewardship, it was a brand new terminology for them, and they said they haven't heard it in their pharmaceutical curriculum during their undergraduate studies, so they were clueless about it. Also, when we evaluated the doses of the antimicrobial being dispensed, we found that the doses being dispensed based on the financial needs of the patient. So if the patient's saying, give me 5 tablets, the pharmacist will give 5 tablets. If the patient says, give me 2 boxes, the pharmacist would give 2 boxes, regardless what's the quantity and the duration of the treatment being mentioned in the prescription. Regarding the collaboration between the pharmacist and the prescribers, the pharmacist said normally there is no close collaboration between themselves and the prescribers regarding the antimicrobial prescribing. And actually, there is no monitoring for the consumption of the antibiotic they are using or the antibiotic being prescribed. When we asked them about what do you know about any initiatives, they said actually there is a lack of activities and initiatives related to the wise use of the antibiotics at the pharmacy levels, and we do not have any guidelines on the use of the antibiotics being issued either nationally or regionally that we can use to prescribe or maybe recommend or not to recommend the antimicrobial agents for the patients that we do see. In addition, that pharmacy, they do receive, or pharmacists, community pharmacists, they do receive a lot of phone calls and they do provide consultation over the phone without having clear data about the patients, anything about the comorbidities or other medications they are taking. So actually, I think that community pharmacists, they do contribute negatively to the antimicrobial resistance in different scenarios or different situations. Thank you very much.
Thank you very much, Nirmeen. Our next speaker from the protagonist side is Victoria Rutter. Over to you, Victoria.
Thanks, Sabiha. Good afternoon, good evening, good morning, colleagues and friends from around the globe. Really excited to be here with you. As you probably know, I'm the Executive Director of the Commonwealth Pharmacists Association, or the CPA. The CPA is a charity that empowers and unites pharmacists across the 54 member states of the Commonwealth, spanning 1/3 of the world's population and encompassing many lower middle income countries, or LMICs as we call them. As we know, rising rates of AMR globally continue to pose a grave threat to human health, and lower middle income countries are disproportionately affected, partly due to the high burden of communicable diseases. One of the CPA's focus areas since 2017 has been AMR, and we believe pharmacists have a unique and key role in tackling this major global health threat. There's a wealth of evidence for pharmacists' key role in ASP interventions, as you've heard from Debbie and also from Carissa. And actually, we could probably have won the debate based solely on the evidence that's already been presented. But I would like to give you a different angle and focus on our Commonwealth Partnerships for Antimicrobial Stewardship programme as a case study. The Commonwealth Partnerships for Antimicrobial Stewardship, or CPAMS, as we call it, was developed to help tackle AMR in LMICs, low middle income countries, taking a partnership approach focusing on antimicrobial stewardship interventions, which included use and surveillance data, infection prevention and control, and thirdly, building pharmacy AMS expertise and capacity. If this was a court case and we were to move on from the evidence and call on our expert witnesses to support our case, my first would be the UK's Fleming Fund, which funds the CWPAMS programme. The Fleming Fund is a £265 million UK aid programme supporting up to 24 countries across Africa and Asia to tackle AMR. The fund is managed by the Department of Health and Social Care and invests in strengthening surveillance systems through a portfolio of country and regional grants, global projects and fellowship schemes. The original CPAMS programme was launched in 2018 as a result of many months of discussions between the CPA and the Fleming Fund, through which we identified that AMS was a key and currently under-resourced component of their work in LMICs, and that pharmacists were key healthcare professionals that could help to lead in this area. Therefore, one of the objectives of this programme is specifically to develop pharmacy AMS expertise and capacity. So not only do we at CPA believe in the key and unique role of pharmacists in AMS, but the Fleming Fund and the UK Department of Health is also convinced, as are our partners, the Tropical Health and Education Trust, or THET as we call them. In order to deliver this programme of work, the CPA partnered with THET to enable delivery through their tried and tested health partnerships model. CPAMS was the very first health partnership programme that THET had run, which included pharmacists as key members of the multidisciplinary team because of their recognised role in AMS. Lastly, our partnerships believed in pharmacists as protagonists for tackling AMR, based on the overwhelming response from our multidisciplinary team applicants that believe in building the pharmacy capacity to strengthen AMS. Many of these are volunteers giving their own time to support this programme. In fact, 4,151 volunteering hours were given from the NHS, and 289 volunteers from low middle income countries were involved in the initial programme. The programme launched with 12 partnerships between the NHS and health institutions in Ghana, Tanzania, Zambia and Uganda. It's been so successful that we've recently extended this to 4 more countries: Nigeria, Kenya, Malawi and Sierra Leone. And recently we've launched 14 new partnerships across the full 8 countries. Pharmacists had key and often leading roles in all of these partnerships. Such is the key role of pharmacists in AMS that the CPA developed and in parallel ran the Chief Pharmaceutical Officer's Global Health Fellowship Scheme for UK pharmacists who were part of the partnerships to develop leadership skills and help enhance their contributions to AMS at all levels of the system. This was supported by Health Education England and was so successful that another round of fellowships has been launched this year. We've also completed a scoping study looking at what a similar fellowship programme could look like for African pharmacists who were part of this CPAMS programme. There's been overwhelming interest from pharmacists, but also from key national stakeholders who recognise the role that pharmacists have in tackling AMS. And we hope to launch additional fellowship opportunities in mid-2022. It's clear that there is strong support for pharmacists as protagonists for tackling AMR, but what have the partnerships delivered? What's been the impact? Some of the key achievements include 3,300 health workers trained across Uganda, Ghana, Zambia and Tanzania in AMS principles, antimicrobial prescribing, consumption, surveillance and IPC. 96% of health workers tested demonstrated improved knowledge after this training. 20 new or revised documents related to AMS
seconds, Victoria.
And antibiotic prescribing have been developed. 23 guidelines and protocols have been rolled out in overseas institutions, and 12 overseas institutions have collected and fed back on AMS consumption data through the Global Point Prevalence Survey. 80% of the institutions also introduced the principles of WHO-aware antibiotic categories. So I conclude, pharmacists are protagonists for AMR based on the evidence, the overwhelming support we have from key stakeholders, and the proof of the impact we can make as a key part of AMS teams. Thank you.
Thank you very much, Victoria. Our last speaker for the antagonist team before the summation and rebuttal takes place is Andy Gray. Over to you, Andy.
Oh dear, oh dear, oh dear, Sabiha. Are we the missing link or are we just plain missing? I'd love to throw another question to our audience today. What is the antimicrobial consumption in defined daily doses per 1,000 inhabitants per day in your area? And how has it changed over the last 5 years? How many of our pharmacists are going to say, DDD what? We claim to be the custodians of medicine. We should also be the custodians of the data that reflects how medicines are used. Who owns those prescriptions? Who knows what the sales volumes were? Who is able to apply pharmacoepidemiological principles? Who can get a good handle on denominators and calculate DDDs per TIDs? Pharmacists can, but do pharmacists really do that? Or are we hiding away behind government's failure to provide us with the data? Who's really the protagonist? Who is driving forward this area of work? It's related, in addition, to the very difficult problem of electronic health records. In many parts of the world, not only in low and middle income countries, our health systems are fragmented, our health records are paper-based, and we don't combine those health records in any deliberate way in order to look not only at process issues, but at outcomes. So what is the mix of antimicrobial use within each of our areas? And is that appropriate to our pathology. I'd like to throw another question to our audience. Who can give me a definition of the AWARE criteria that WHO uses to classify antimicrobials? There are many parts of the world where the issues are not only the requirement to watch and restrict, but we have to ensure access. Are pharmacists part of the solution to the access challenge, or are they merely enablers of inappropriate use, as we heard from both Manjari and Nirmeen? The evidence, I'm afraid, stacks up against us. We have the potential. We know what to do. We know how to do it. We just fail to actually do it. Let's finally bring it down to the narrow, to our own practice environments. Can we disaggregate the data that we do see, perhaps from government? Do we know how that affects our communities where we are practicing, and what our individual utilization patterns look like, or how those have changed over time? Are we contributing to the problem, or are we addressing the problem? And I do worry, Sabiha, that we have filled pharmacists' heads with the knowledge. We have imbued them with the attitudes. We have ensured that they have the competency, but we have failed to get them to move and actually do what it is that they are capable of doing. And in that way, we are still antagonists in this global problem. Thank you very much.
Thank you very much, Andy. That was your 5 minutes as a panelist. You will have one more opportunity to provide a summation and a rebuttal. So Parisa, as the lead of the protagonists, it is your opportunity now to take stock of everything that has been said, both from your side and from the side of the antagonists. Give us a summation and also rebut what the antagonists have said. Over to you. Your 5 minutes starts now.
Thank you, Sabiha. As everyone in the audience, the nearly 340 participants who are keen on this topic have heard from our team, from Debbie and from Victoria, pharmacists are protagonists in the effective and appropriate use of antimicrobials. We have seen a lot of evidence from our speakers earlier, from this team, on the impact and the role of the pharmacist. And we've also are aware of quite a substantial amount of evidence in the literature. You've also heard about the skills, the knowledge, and the expertise that pharmacists have, and the vast array of roles that pharmacists can do. Now think global. Think about all the pharmacists in all places of work, especially community and hospital, and think about the impact that all of these pharmacists have had and continue to have. Don't focus on the one or two or groups of pharmacists that have been presented by the antagonist team. Don't let the argument be clouded with being told about data collection and whether, as pharmacists, we understand what data means. We're there at the face to deal with patients, to educate patients, to optimize their use, and we have shown that we can optimize use. We're there to make a difference to the way prescribers provide antibiotics, and we have shown that we can make a difference. We've been told that antibiotics are being provided over the counter without prescriptions, and we know that that happens in some parts of the world. But we also know that, as was so aptly put by one of my learned colleagues, that the ecosystem is also responsible for some of the poor behavior we may see. And that can be true in some cases, but we can't, as pharmacists, blame others when the evidence is so strong around the positive impact that we have. Now, when pharmacists do provide antibiotics without a prescription, evidence has shown, in fact, some of the work we did in Sri Lanka, that it's not the pharmacists as such, it's the technicians that work within the pharmacy. And when pharmacists have been questioned around their practice In fact, they come up with valid reasons for why they are providing antibiotics, noting that in many cases where you're working within a lower socioeconomic background, people with viral infections can soon get a secondary bacterial infection. So pharmacists have some rationale in terms of what they're providing. So in summary, I'd like to stress the fact that the evidence is strong. We have the expertise, we have the skills, we are doing the work. There are some parts that will need to do more, that is as shown, but overall, globally, we have the power, we have the evidence, we have the policies, and we have the strength and the communication to make the difference, and we continue to do so. Thank you, Sabiha.
Thank you, Parisa, for that summation and rebuttal. Andy, over to you.
Thank you very much, Sabiha, and thank you, Parisa, for, I think, telling us what it is that we wished were true. We have the power, we have the knowledge, we have the evidence from pilot projects. The key that we have to ask ourselves is, are we taking it to scale? Is this something that the world can rely on pharmacists to be doing everywhere, all the time? And I think that is one element that I'd like to bring up. We've had good examples of pilot projects. We've had good examples of interventions. We've got great evidence. But we know from clinical medicine that evidence doesn't always translate into reality. And what pharmacy has to do is take responsibility for the continued barriers to implementation at scale. But I think we also need to focus to some extent on the issue of individual responsibility versus the health system's design. We know from the literature on medication errors that individual decisions are less important than the way in which the system makes those individual health practitioners actually practice. So what is it in the overall health system of many countries that argues against effective pharmacist interventions in antimicrobial stewardship? I would argue that our biggest problem is our inability to arrange our health systems in such a way that we ensure universal health coverage without, at the point of care, out-of-pocket payments. It is out-of-pocket payments and the desire of people to get help when they are sick that is contributing most to inappropriate off-prescription sales of antimicrobials, and also inappropriate prescribing of antimicrobials, and a difficulty for pharmacists to intervene when they see that inappropriate prescribing. What are we as a profession doing at a global level, but also at a national and a local level to push our health systems towards universal health coverage with reduction in financial pressures on those who are sick? So yes, we have potential. Yes, we could be the protagonists. Right now, I'm afraid we are still a little quiet, and we are great at pointing to shining stars and saying, look what is possible. What is actually happening is where we are weaker. Thank you very much.
Thank you very much to both the teams, the protagonists as well as the antagonists. We have a few minutes to take a general discussion or perhaps some questions and answers from the participants. Maybe I can just ask one or two and just ask the protagonists as well as the antagonists to comment on this. So the first one is, I strongly agree that the fault was not only focused on the pharmacists. Some of the pharmacy stores, without the supervision or presence of the pharmacist, especially on the community, dispenses antimicrobials without the pharmacist. So that's more of a comment. And then a second one is regulation and enforcement and stewardship seem to be generally well established in hospitals, but in countries where the regulatory framework is not strong, antimicrobials are available without prescription. How do community pharmacists take a stronger and more effective role? So I'm going to open it up for a few minutes, 5 minutes in total, for anybody from the protagonist or antagonist team to answer. So please switch on your video and go for it. Andy, you first.
So thanks. I'm going to start by saying, although community pharmacy is a very important part of where our problems lie, let's not let hospital pharmacy off of the hook, because that's where some of the most broad spectrum antibiotics and some of the worst resistance problems are actually happening. But certainly in community pharmacy, enforcement and checking and following up on what is actually being bought and sold and prescribed and dispensed is really, really important. Otherwise, we are always going to be in the dark. Thank you.
Marjorie, you're up next.
Thanks, Sabiha. I agree with Andy. So the community pharmacy, people coming and asking for the antibiotics, it's a big challenge, but it's a big opportunity also. That's where we need the role of the pharmacist, because pharmacist needs to communicate with the people, counsel them, educate them, sensitize them regarding why for every ill there is no antibiotic. I mean, we should not be asking for the antibiotic. So if every pharmacist is doing that role in the pharmacy, then that is going to make an impact. Today, what happens is maybe just 1 or 2 pharmacists would like to do that, but then rest all, the large proportion of the pharmacists just dispense anything and everything that is asked on the counter. And so community pharmacy is a very challenging, provides a lot of challenges, but also an opportunity to show our role. That's where we can make difference in the lives of the people. I give you an example of a person coming and asking for, asking for a medicine for the stomach upset. Can we not dispense ORS? Can we not dispense some other OTC products? So that's where is the role, and the community pharmacists have to realize it. And also, as I have always said, we need to create an ecosystem for it. And that's where we can contribute to. Thank you.
So I've just had a question in the chat in terms of the definition of protagonist and antagonist. So a protagonist is somebody that will improve the antimicrobial resistance situation by virtue of their professional practice. An antagonist is also within the professional setting, somebody that will disadvantage or do more harm or increase the levels of antimicrobial resistance. So that is the negative and bad practice situations, just for clarity in terms of the use of the words protagonists and antagonists for that. We have 2 minutes. Does anybody else want to further the case or look into the chat, which is really, very lively, as well as the Q&A section to answer? Parisa, I see you. Please go ahead.
I am going ahead. I just want to, I guess, stress that while we focus on AMR as to do with inappropriate antibiotic use, we have to also remember that antimicrobial resistance is a natural process in bacteria, that it happens, and we can't focus totally on inappropriate antibiotic use as the one and only cause of AMR. So that has to be put into context. And I appreciate that pharmacists alone are not the solution to the big global problem, but pharmacists are a key, and I'll come back to the missing link, that has gone from poor practice to very good practice based on the evidence provided.
Thank you very much, Parisa. Nirmin, you get the last word.
Yeah. Actually, although I was in the antagonist side, but I think it's totally unfair to put all the load for the pharmacists. We are ignoring all the time the role of the physicians and the prescribers and how much they do contribute. So I think we need to have some sort, especially at the level of the academia, related to the interdisciplinary education and teaching and having both of them coming together. so they can agree on things together. So we need to be fair with the pharmacists at any point, not only the pharmacists.
Thank you very, very much to all of the team members, the protagonists, as well as the antagonists. You certainly made strong cases for each of your perspectives. And what we're going to do now is go to the polls to let the more than 300 people that have been participating and listening in to decide. So, Carola, can we have the first question, please? So the first question relates to the antagonists. That's Andy, Manjiri, and Nirmin. The antagonist case studies presented are similar to the experiences in my own country. So please respond. This is not the deciding question. This is just to ascertain whether the case studies are also resonating with you and your professional environment. So do you strongly agree, somewhat disagree, or strongly disagree in terms of the antagonists case studies? That was the Andy's team. Please go ahead and vote. So these were the bad practice examples where pharmacists are hindering progress to mitigate antimicrobial resistance. And we have results. So many participants can identify with some of the case studies that have been presented by the antagonists. So it seems that bad practice may be somewhat far more common than we would like it to be. So thank you very much for that. Can we have the next question, please? And the next poll questions, I think, then relates to the protagonist case study. So these relate to Parisa's team. The protagonist case studies presented are similar to the experiences in my own country. So these are the good practice examples. And do you strongly agree, somewhat disagree, or strongly disagree? So this is where the professional practice is good practice. Has everybody had enough time to vote? Okay, and sorry, we're going to rerun that poll. Question 2 on the protagonists. So please vote now. I think we might be having a bit of a, there you go. So again, there is also examples of good practice that is resonating with lots of the participants here today. So in both instances, in terms of the protagonist team as well as the antagonist team, there is, people can identify with both good practice and bad practice. And we're all very aware as pharmacists that we have examples of both aspects. And now the time to decide on which team was the winner. So please, we are all pharmacists and we would like to think that we are doing a really great job, but we need to be absolutely honest with ourselves. And we need to also, in this instance, look at the presentations that were made by the two teams, the protagonists and the antagonists. Please look at the content of the examples and the illustrative case studies that were given, and please decide very carefully who made the better case. The protagonist team with Professor Alsani, Professor Goff, and Dr. Rutter, or the antagonist with Professor Sabri, Manjiri Garat, and Andy Gray. This is the deciding factor. And let us see who are the champions in this debate. Please vote now. We almost need a drum roll here. Okay, 58-42 to the protagonist team. Well done, well done. Congratulations, Parisa and your team. I'm going to stop sharing my slide if you would like to make one statement as the winning team.
Can I also get my team members to come on? I'd like to take this opportunity to thank Debbie Goff and Victoria Rutter for making very compelling arguments and cases. Thank you, Sabiha and Manjiri, for organizing and for FIP organizing. And to Andy, Manjiri, and Imran, you did an excellent job. You nearly convinced us, but not enough. Thank you.
Andy, one
word. I'd have been gutted if I'd won as a pharmacist and a pharmacy academic. Thank you, Parisa, for putting me in my place. Thank you.
Okay, so then I would like to conclude with just a few concluding remarks, please. I'm sorry, I'm going to share my screen again. Sorry, a bit of a technical glitch there. Sharing. Okay, so Manjiri, over to you in terms of the way forward with the FIP AMR Commission.
Thank you, Sabiha. And it was really interesting debate. And congratulations, Parisa and team, the protagonist. So we would like to be there. So the next steps for the FIP AMR Commission, the Commission will continue to monitor the progress on antimicrobial resistance roadmaps annually and stimulating the global community pharmacists to be an active agent in minimizing AMR. So that's where I said we need to go, and we would love to be protagonists, and we would like to minimize the AMR and enhance the contribution of the pharmacists in minimizing AMR. So thank you, Sabiha, and over to you.
So thank you very much. Just a few words from GRIP. So GRIP are committed to driving behavior change in AMR. Moving forward, the partnership will review all initiatives that with a view to accelerating and supporting the adoption of these initiatives that bring about most behavior change. So we will be taking a very close look at the case studies with a view to scale up. And if you want to have more information on GRIP, please look at this website that is on the slide. Before I hand over to Catherine, I just want to say that you will agree that this has been an outstanding session, something different from the norm. We had an excellent debate with excellent speakers, and thank you to all of them for sharing their extensive knowledge and experience with us. It has been an invaluable learning experience. A special thank you to all of the participants for your contributions and your questions and your polling. Very special thank you to Carola, Susanna, Mila, and the team at FIP, and Jordan, Ashlyn, and Erin from Cello. Your technical support and attention to detail makes our role as participants very easy. Catherine, over to you for the closing remarks.
Thank you so much, Sabiha. Thank you so much, panelists. A couple of reflections of me as we move to closing. We had case studies presented from all regions, and these were greatly thought-provoking, showcasing pharmacists' existing activities to minimize AMR and to demonstrate the role that our profession has as a commitment to contribute to the solution. Final congrats to case study number 5, the winner of the winners today. But congratulations to all who've been involved. I think the involvement and participation has been superb in the whole of this programme. And I wanted to say a huge thank you for that. We can all agree that despite the AMR crisis we face, the stewardship from our profession across all regions is second to none. But we can't rest on our laurels. We cannot be complacent. The examples of innovation we saw are not only impactful, but practical and useful. And I would echo Sabiha in urging you to access the recordings on the FIP YouTube channel. But colleagues, from the debate, we still see a lot of barriers to address. We see a lot of new efforts being done to overcome the barriers, but we all need to acknowledge the tensions that exist between the direct sale of products, the judicial use of antimicrobials and antibiotics, and the use of our professional oversight in antimicrobial stewardship. This is a continual challenge and one we need to address with facts and evidence and promotion of professional judgment over commercial interest. I found today's debate to be fabulous. It's about being open and honest about the two sides of the argument so that we can reach a way forward. And these events also showcase the importance of partnerships. Sabiha, you said thank you, but I would echo all of those thanks to the teamwork we have, but to all of our speakers and our partners involved in this endeavour. To the audience who've stayed with us during this time, we hope these debates have inspired you not only to think about solutions locally, but to develop some of the examples you've seen in your own settings. You have seen the wealth of resources, guidance, training, evidence, and toolkits for our profession. And at FIP, we do not want to duplicate, we do not want to replicate, we want to build on what is strong in practice. The next steps, the FIP Commission on AMR will monitor the progress on our roadmaps annually, and we'll do that at various times of the year to stimulate our global community of pharmacists, to stimulate you all to be a great active agent in minimising AMR through great examples of stewardship. So as we come to the end of this amazing session, and I must say, amazing, we need to use this methodology in different ways. It's really kept us all entertained while addressing a very serious issue. Let's keep ourselves engaged, empowered, educated, and embedded. As Andy said, we can't be the missing link or missing from this. Our role in stewardship as the custodians of medicines use globally is central, and we need to play our part in that. Super session. Thank you, colleagues, and super leadership from all involved. A pleasure to be involved. Thanks a million.
Thank you very much, everyone. It was excellent. Have a good day further.